this only compound, probably one of the healthiest family in the world. Of course, due to all these reasons, availability of opioids, increasing number of prescriptions, the number of fatalities attributed to opioids increased during the 21st years of our century. They increased till about 2010. And you see here, there was a plateau in the number of opioid fatalities, just related to the fact that the American health authorities decided at that time in 2010 to ban from the American market just one product, which was the oxycodone that is able to be crushed and injected intravenously. So just at that time in 2010, just the banning of one compound from the market allowed to plateau and to stop the increase in the number of fatalities attributed to opioids. But what was the problem? Immediately, you observed here in red a decrease in the number of fatalities attributed to oxycodone, you see, but concomitantly, an increase in the number of fatalities attributed to heroin. So what was the problem? The health system in the US created opioid-dependent patients. When the health authority decided to ban oxycodone, which was abused by intravenous injection, these patients switched from oxycodone use to heroin use. And in 2010 till 2015, heroin reappears in the US, and the number of fatalities attributed to heroin re-increased once again. So it was not a success. And you see on this slide that the shift between the abuse of oxycodone and opioid analgesics to heroin was like simultaneously. You see that the number of prescription opioid use decreases, and in the same time, the number of heroin increases, like in a parallel way. So this really supports the fact that the development of opioid use in the US was only related to the development of addiction. So first reason, opioids are available, more and more available. Second reason, you created opioid-dependent patients in the country due to huge number of prescriptions. And even if you modify the kind of molecules that are available, patients are dependent, so they will change from one opioid to another according to availability. The third reason, of course, is that opioids are responsible for neurorespiratory depression in case of overdose or misuse. You know that the control of ventilation is related to centers located in the brain stem and mainly in the pons and the upper part of the medulla, And you see here these two centers, the pneumotaxic center and the apnostic center. And these centers command those responsible for the contraction of the inspiratory muscles, and those are mainly located in the dorsal respiratory group center, and you know that inspiration is active, related to the contraction of inspiratory muscles due to these inspiratory neurons, while expiration is only passive, related to the fact that inspiratory neurons stop to stimulate the inspiratory muscles. So inspiration is active, related to contraction of the muscles, and expiratory is passive. And of course, in these centers, you have opioid receptors, and that is the problem, because opioid receptors are expressed in the centers that control ventilation. And you know that stimulation of these receptors, mainly mu receptors, will cause a dose-dependent depression of respiration. So all mu receptor agonists will induce respiratory depression. And this depression is related to a reduction in the brainstem sensitivity to CO2. It is related to a depression of pontine and medullary centers involved in this rhythmic respiration. It increases the apneic threshold, it decreases the hypoxic drive to respiration, and even it has some activity on peripheral centers like carotid body chemoreceptions. This depression is characterized by a dose-related depression of the resting ventilation with a reduction in the tidal volume, a reduction in the respiratory rate, and of course a consequent decrease of PaO2 and increase in PaCO2 with the onset of respiratory acidosis. Probably the mu2 receptors and some of the delta receptors are responsible of these side effects, while kappa receptors seems not involved or even protective in some models. So the centers of respiration are in the brainstem, and you have opioid receptors in the brainstem. So opioids are able to depress respiration, and that is the reason for the danger. And this is clearly demonstrated that when you use an opioid, even at therapeutic dose, you may develop respiratory depression. And you see on this slide, in relation to the dose of your opioid, and here morphine equivalent dose, you have an increase in the number of apnea during your sleep. So if you are treated with an opioid, you may develop apnea episodes, mainly during your sleep, and you may die, of course, if this apnea is prolonged. And this is related to the dose. And this apnea, these apneic episodes may, in case of an overdose, goes till the onset of an opioid syndrome, which is the usual presentation of an opioid overdose. And you know that opioid overdose presentations includes impairment in consciousness, meiosis, and bradypnea. And these three symptoms are characteristics of the opioid toxicity. And SpO2 and respiratory rate are surrogate indicators of ventilatory drive, although they provide rather limited information on the drug effects on ventilatory control, while the minute volume and the PaCO2 are the best markers to measure the ventilation, but unfortunately they are more difficult to access directly at the bedside. when you prescribe an opioid, you have to know that you increase the risk of fatality in your patient. And you see here, if you prescribe an opioid to a patient during 1 year, you will increase his risk of death by 50 times. So the availability of opioids, the increase in the availability of opioids will be related to the increase of the risk of death in the population. But the dose is not the only problem. That's an important point also to understand. There is, of course, a quite good relation between the dose and the risk, but the dose is not only the problem. And you see that on this slide. We compare in this slide the concentrations of various opioids, here methadone, and here buprenorphine and its metabolite norbuprenorphine. In the first line, in patients who died directly from an opioid overdose. And in the second line, in patients who were opioid users but died from another reason. And you see that the concentrations are almost the same. So it is not so obvious that death attributed to an opioid overdose is in relation to the dose or to the concentration. So there are risk factors for the development of opioid overdoses. Of course, one important reason is the molecule you use, the opioid. And you see here that the risk of respiratory depression from prescription opioid overdose is not the same, and it depends on the molecule. And you see clearly that fentanyl and methadone are the most dangerous molecules responsible for a highest number of fatality rate, while codeine probably and maybe tramadol are less dangerous. And you see, if you take one for the risk with codeine, you have about 22 for fentanyl and 14 with methadone. So the molecule is important. And of course, some of these molecules may also have additional mechanism of toxicity, and we will discuss this during the symposium. Like, for instance, tramadol is also a serotoninergic molecule. So all these additional activities on different receptors will contribute to the toxicity in relation to opioids and will increase the risk of complications and side effects. And fentanyl is very well known in this area because fentanyl may be responsible also for chest wall rigidity that contributes to the toxicity. And this complication is relatively well known and was suspected based on several observations from fentanyl-related fatalities. With fentanyl, death occurs in the therapeutic range in apparent non-naive opiate abusers. And that clearly questions the onset of dose-dependent respiratory arrest as a mechanism of the death. But also when you analyze these cases, there is a lack of measurable metabolite, norfentanyl, in almost half of the cases. And so that supports the fact that the death occurred very rapidly, probably in relation to this acute chest rigidity before the expression of a neurorespiratory central depression. So you have additional mechanism of toxicity with fentanyl that increases the risk of fatality onset. And of course, with the multiplication of the different molecules, the different compounds, you have new pharmacokinetic patterns, new pharmacodynamic patterns, and you see that the delay of action, the duration of action is very variable among the different compounds, and this is a difficulty to manage opioid-related toxicity and increases the risk, of course, among the patients. One important point also is the mechanism of toxicity in the chronic users. And this is related to the development of tolerance, but also abstinence. So there are two theories to explain why people used to use opioids are at risk of death. The first hypothesis is the tolerance theory. When you use an opioid, you will develop a tolerance. But it is supposed that the tolerance to the analgesic effect will develop more rapidly than the tolerance to the respiratory effects. So that if you have a tolerance to the analgesic effect, you will increase the dose, but the tolerance to the respiratory effect is still not here, and then fatality may occur. This is the tolerance theory. There is also the abstinence theory. And here, for any reason, a chronic user of opioids may stop his opioid use. And this is well known if the patients go to jail, for instance. Then the tolerance will decrease due to this abstinence. And when the patient will reuse or reconsume his opioids, then he will have a risk of death. And this theory have been assessed based on the measurement of opioid concentrations in the hair, and it was demonstrated that before the onset of an overdose, there is a period of decrease in the concentration of opioid in the hair due to this abstinence period. So you have both theory to explain the risk and the vulnerability of these patients. And of course, as you know, opioid is not the only molecule that is used by opioid abusers. And if you analyze the hair of those who died from opioid overdose, you may find almost all kind of psychotropic drugs in the hair. So they abuse many drugs, licit and illicit drugs. So there are interactions between all these molecules, either pharmacokinetic or pharmacodynamic interactions, and these contribute to the onset of fatality. Finally, of course, you have to know also that there is a genetic vulnerability among some patients, and this support an increased risk of toxicity. Probably all of you know this very famous case, and this was a woman who came to the emergency department after the delivery of her child, but unfortunately her child died a few days after delivery. And it was demonstrated that she fed him with her milk, and she was treated with codeine at pharmacological doses. But she was an ultra-rapid cytochrome 2D6 metabolizer, and due to this genetic pattern, she produced morphine from codeine instead of producing norcodeine, which is an inactive metabolite. And this milk rich in morphine was responsible for the death of her child. And since this case, codeine is forbidden during during lactation, during breastfeeding in women. So it's a relatively new contraindication. But this is not only the only case. and you have also genetic related vulnerability with other opioids. And this is the case, probably less known, with tramadol. You see that tramadol is metabolized in two active metabolites. M1 with cytochrome 2d6 pathway, and M2 with cytochrome 3a4 pathway. And this patient who overdosed with tramadol presented a very severe cardiovascular failure, which is not supposed to occur because tramadol has not so severe risk of cardiac toxicity. And it was demonstrated that this patient presented a very severe cardiovascular toxicity due to the fact that he was an ultra 2d6 metabolizer, so he produced M1 metabolite from tramadol, but also in the same time, a few days before his poisoning, his general practitioner prescribed him ketoconazole, which is an inhibitor of cytochrome 3a4. So he blocked this route, and his tramadol goes only in this way by the cytochrome 2d6, and he produced a very elevated amount of M1 metabolite, resulting in the observed toxicity. So gene vulnerability is important. The fourth reason for the crisis is the emergence of the new recreational opioids. And this is really the most important problem today. And to let you understand, I have produced this slide, and please, we will follow each line to understand, and you will see that there is 3 phases for the opioid overdose crisis. So if you remember, the first one, the first crisis, the first reason is the prescription of analgesics by the physicians, and mainly by the emergency medicine physicians. So follow this line, prescription analgesics. You see that there was an increase in the number of prescriptions of opioid analgesics and the number of fatalities till about 2010. And then, as explained, just here, there was a plateau in the number of deaths related to analgesic opioids, just related to the banning of crushable oxycodone from the market. But immediately, as you remember, there was an increase in heroin. Follow this line. You see here that heroin is relatively low, and then it increases here when oxycodone was banned. So this explains the second wave of deaths related to opioid overdose in the US. And this is between 2010 and 2015. And then follow the blue line. And you see that this is related to fentanyl derivatives. And it was relatively low. And then about 2015, it goes up like in a vertical way. And this is the fentanyl-related fatalities. And to date, it has been estimated that almost 85% of the opioid-related deaths in the US are in relation to fentanyl derivatives. So now, the physicians created the patients, the dependent patients, and now the patients change from analgesic opioids to heroin, and from heroin to fentanyl, because of availability and cost, of course, because heroin, you have to bring it from Afghanistan, and it's expensive, while fentanyl, it's produced in the US territory, and it's like a pharmaceutical presentation, so it's more safe. You know exactly what you have inside, and it's much more available in the market. You can buy it from internet, from the darknet, without prescription. So this is the new recreational drugs. And why fentanyl? Because fentanyl is a complex molecule, but you see that it is easily changeable. You can create new derivatives based on chemical synthesis, and this is relatively easy to do. This is relatively easy to do, and you can produce very powerful molecules. And you know that probably some of these molecules are 10,000 times more powerful than morphine, even than the fentanyl. They are so powerful that some of these molecules, like carfentanil, and we'll have during this day a presentation on carfentanil. Carfentanil is available, but it has no possibility to be used or prescribed to humans because it's so powerful. It is used for elephants in the veterinary medicine, for elephants and rhinoceros and so big animals, but not in humans. But you can buy it on the internet easily. And you see here in Europe, we have the same problem. And you see here the number of seizures related to the new psychoactive substances. And in red here, those who have opioid activities. And you see a relatively evident increase in the amounts of opioid-like NPS during the years. And here, how you can buy them. You see here, this is a bottle with butyryl fentanyl, and it contains the amount to allow about 100 puffs. So you can buy this bottle from internet, and you can go to a party and use it. And you imagine the number of possible deaths among the people who will use this or misuse this in the party. So it's really dangerous. One interesting point also is to know that these fentanyl-related poison patients will present with the usual traditional opioid presentation. That means consciousness impairment, meiosis, bradypnea. But you see in these patients, the onset of some aspects, some clinical aspect, may question and may probably suggest to the physician that toxicity is related to a fentanyl. And you see these patients may present tachycardia, may present hypertension, may present renal insufficiency, agitation, which are not common features with the usual opioids. So such features may question the possibility of fentanyl derivatives. Sometimes you may have additional symptoms, like here, acute skin and hair symptoms with this synthetic opioid called MT45. And you see you have the development of a folliculitis and dermatitis in the patients that may suggest the use of these opioid derivatives. But of course, one important issue is the toxicological analysis, because to really know which compound is responsible for the toxicity, you will require an analysis, a solid analysis, based on the use of complicated technologies, including liquid chromatography coupled to mass spectrometry, and you see that you have to probably use mass spectrometry in tandem or very sensitive spectrometry. And this is not available in all the countries and in all the hospitals. So that the final diagnosis is sometimes difficult to assess. And that's why in many countries you have no figures, no statistics, because you have no solid and pertinent possibility to make these analyses. So what to do? Finally, what to do? Last chapter. Of course, it is important that the physicians have to be aware about the risk of opioids with reasonable prescriptions, supervised dosing with long-acting opioids, and of course, the health authorities have to limit the access to the market of the most dangerous opioid molecules and to support the spread of opioids with better therapeutic ratios. They have to regulate the market of illicit opioids, and we will discuss this during the symposium to allow a multidisciplinary approach of opioid addiction, and this is important, with maintenance treatments, with different policies like supervised injection sites or needle exchanges. But this is not enough. Hopefully we have an antidote, and this is a very efficient antidote. It is naloxone, which is a pure opioid antagonist at the mu, kappa, and delta receptors without any agonist properties. And this antidote is available worldwide. It has been widely used to reverse opioid toxicity, is efficient. It is responsible for a dose-dependent reversal of opioid agonist effects, and it is relatively easy to use, although there are some inconveniences. We'll have time to discuss about this, because it may precipitate acute opioid withdrawal syndrome if not well used in the patients. But anyway, it is efficient, so we have a real efficient antidote. And it has demonstrated that in the majority of the cases, almost 80% of opioid fatalities, the death occurs at home 1 or 3 hours after the exposure and in the presence of a bystander. But this bystander do not do anything that is useful for the patient. He just observed the patient. So BCLS by bystanders are usually ineffective, not sufficient. And there was in the US and now in many European countries the development of a policy of preventing opioid overdose deaths with take-home naloxone. What is take-home naloxone? Is the prescription of naloxone to all patients who are opioid users so that they can put this naloxone at home, and in case of any problem, the bystanders, the family members, will be able to use the naloxone mainly by intranasal or intramuscular administration to prevent the risk of fatality onset. And you see here that this policy allows in the US the prevention of about 25,000 fatal overdoses in the last years. So it is really effective, and it's now developed in the European country. I don't know if it's available in Turkey, but you will tell us. So in conclusion of all this overview, opioid-related toxicity represents a challenging health concern worldwide. There are several reasons. The first reason is the increase in prescriptions with the increase in availability. And of course, this was based on inadequate prescriptions in the majority of the situations. The second reason is the development of dependence. If you use an opioid, then you will develop dependence, tolerance, and there are risks related to tolerance and, of course, abstinence if you stop using opioid during a certain period of time. The third reason is the individual vulnerability, and this vulnerability is related to gene, but also to non-gene explanations and reasons. And the fourth problem, of course, is the emergence of opioid, new psychoactive substances on the market. So all these reasons explain why we are facing now a crisis of opioid overdoses in the US, but also in the whole world, and in Europe for sure. I don't know in Turkey the situation. So preventing opioid overdose deaths appears as mandatory. It could be achieved with some policies like maintenance treatments, take-home naloxones, but of course for the future, new strategies based on preclinical findings have to be developed, but of course with more uncertain timelines for such developments. So thank you very much. We were in connection with Omani resident staff, and now my presentation is open to questions from you, from the audience, and maybe from the residents from Oman. Thank you very much. So please, any experience or any question? Yes, please. Maybe with the micro, because...
Dr. Hassan from Oman. In the hospital that I practice in, we have a lot of sickle cell disease patients who are, most of them are dependent on opioids. What we use there, or what have been used since the last more than 15 years, they used pethidine to control their pains. So then they became dependent to pethidine. Like per day, they are coming, each one of them is coming around 3 times per day because he is dependent on pethidine. And each visit, he will take around 200 to 300 mg of pethidine. So I don't know if there's any alternative to that, how to solve this issue, and like if we can shift them to something else, and how easy it will be. Because they continued on that, because it was started by hematology since more than 15 years back.
That's a good question, if I understood everything. That's a good question. I think we'll discuss this later on, because we'll have different presentations on how to allow the treatment of dependence with different policies, with maintenance treatments, and you will have different approaches, because you will have the Iranian approach, which is quite different from the French approach, and you have different possibilities. But it's a complicated problem, and there's not one solution for that problem, of course. But as you understood, really, if you prescribe once an opioid, then you expose your patient to the development of a dependence. And then the problem is difficult, and you expose him to the risk of respiratory depression if he misuse his opioid or if he overdose. Another question?
Do you have any questions there?
We are waiting for Omani. No. No question. Okay. Okay. So we will stop. Okay. We have stopped the communication with Oman, and now we'll back to our symposium. So we have changed a little bit the organization, and now we'll start again. I suggest to continue with the opioid receptors, which is the first presentation that was expected.